Hi, my name is Dr. Bruce Liese. I am a psychologist and professor of family medicine and psychiatry at the University of Kansas Medical Center. Also the clinical director at the Cofrin Logan Center for Addiction Research and Treatment. I've been asked to make a presentation on cognitive behavioral therapy, and I am delighted to do so. These are some of the basics, and I'm sure the future recordings will include some more of the more complex concepts in cognitive behavioral therapy, but this is a good place to start. So, cognitive behavioral therapy. First, let's define cognitive behavioral therapy. As you can see from this slide, it's a set of therapeutic approaches designed to help people with mental health problems, and those include depression, anxiety, personality disorders, addictive behaviors. CBT, which it's also known as, facilitates the development of skills, knowledge, and effectiveness. The ultimate aim is to help people engage in life more fully and more effectively. A lot of people think CBT is one thing, cognitive behavioral therapy is just one thing. In fact, it's much more complex than that. Cognitive behavioral therapies, as they should be referred to, involve many actually different branded therapies. You've probably heard of something called dialectical behavior therapy or acceptance and commitment therapy, contingency management, mindfulness-based cognitive therapy, rational emotive cognitive therapy, behavioral therapy. These are all different therapies that fall under the umbrella of cognitive behavioral therapy. All of them focus on thoughts or cognitions, behaviors, and of course, they're therapeutic, so CBT. So acceptance and commitment, I mentioned, dialectical behavior therapy. Now, not all of the people who practice these models would agree that these are cognitive behavioral therapies, but that we'll leave that for people to think about. So the cognitive behavioral therapy that I was trained in many years ago was the one developed by Dr. Aaron Beck, which focuses on relationships between thoughts, feelings, and behaviors, but also very deep core schemas, they're called, and basic or core beliefs. So the original cognitive therapy began a tidal wave of scholarly activity, studying depression and anxiety and personality disorders and addictions. The concept of guided discovery, where the therapist asks patients questions so that both the therapist and the patient can determine what's most concerning to the patient, and also so they can start to express what some of the ideas are that might be problematic in their own functioning. It was also known as the Socratic method. So initially it emphasized psychoeducation, like teaching about the relationship between thoughts, feelings, and behaviors. It also emphasized structured techniques, but ultimately it became apparent that much more was needed, a much deeper dive into how people developed their thoughts and feelings was necessary. You may have heard of rational emotive therapy. Most people have heard the name Albert Ellis. Albert Ellis, around the same time as Dr. Beck, came up in the 50s with the ABC model and emphasized rational disputation. If somebody says, "I'm a terrible person," in rational emotive therapy, the focus would be on changing that directly. What makes you a terrible person? Is anyone else a terrible person? What's your evidence for being a terrible person? Dr. Ellis was particularly interested in musts and shoulds. I must do well, others must treat me well, I must get what I want. Those rules were bound to get people in trouble. Acceptance and commitment therapy, Dr. Stephen Hayes, had to do with being present with what life brings and not resisting it. And core principles were diffusion, acceptance, contact with the present moment. So some people argue that these different components of these therapies, cognitive therapy, ACT, or acceptance and commitment therapy, rational emotive behavior therapy, behavioral activation. Some people argue that they specialize in these areas. Good therapy, good cognitive behavioral therapy actually includes all of these different components. Here you see a slide of behavioral activation that revolves around monitoring daily activities, identifying goals and values, and helping people to develop an upward spiral of motivation instead of a downward spiral of withdrawal. So it involves problem solving around barriers to behaviors that are healthy and positive, scheduling activities, and finding ways to reduce those barriers or any avoidance. Mindfulness-based cognitive therapy, again, a lot of the same principles of helping people to examine the way they think and examine how they act, but it begins with the idea that being mindful of the present moment through paying attention to breathing and the body and stretching and yoga, mindfulness, paying attention to what enters a person's mind and separating oneself from thoughts and realizing that they're only thoughts and learning how to let them go. That's more of a mindfulness-based cognitive, or I would argue cognitive behavioral therapy. So before talking about cognitive behavioral therapy, I think it's really important to emphasize that it is not certain things. A lot of people think they have a stereotype view of cognitive behavioral therapy, that it's superficial, mechanistic, that it focuses just on reducing symptoms and ignoring the whole personality, that it ignores early life experiences. These are all misconceptions, that ignores interpersonal relationship factors and the therapy relationship and motivational issues and emotions. In fact, those are all misconceptions. Good cognitive behavioral therapy, when it's done right, pays careful attention to the structure. How well is the therapy organized? How well are people collaborating with each other, the therapist and the patient? Is the therapist listening well to the patient? Are they empathetic? Are they mutually setting goals, not just the therapist setting goals? Are they giving each other and receiving feedback well? And are they working together to develop a careful and sensible and practical and useful understanding or conceptualization of the intrapersonal, which is the inside of what happens in a person's head, and interpersonal, what happens between a person? How well is that case conceptualization of the therapist and the patient being built? So the 5 components, the last 2 are you should be learning in psychotherapy, all psychotherapies, whether you're learning about your unconscious or the meaning of your dreams in psychodynamic therapy, or in cognitive behavioral therapy, learning about your substance use or how your depression developed and how it's maintained. That's psychoeducation. And then all these techniques for making changes, like functional analysis, self-monitoring, daily thought records. These are all approaches that you will hear from various types of cognitive behavioral therapists. So the content of cognitive behavioral therapy is important. The content is how people think, how they act, what their beliefs are, what their values are, what their rules are. That's cognitive content. And it is my belief that you are what you think. But the process of therapy, so not only what you think, but how you think, your executive functioning, how your mind works, like how well you control your impulses, or how well you regulate your emotions or affect, how well you focus, how well you organize, how well you plan. And in a moment, we'll talk about systems 1 and 2. So my preference in thinking about cognitive behavioral therapy is that the interests I have, the interest you should have in thinking about how people operate, is there's what they think, but also how they think. And how you think is the process itself. Some people like to think about, when you talk about what you think, do you distort the way the world works? Like thinking all or none. If you made dinner and you burned one item and the other 3 or 4 things you made were perfectly good, thinking that you completely 100% failed to make a great dinner. That's all or none. When you overgeneralize, like I am not, for example, if you don't have a college degree, that means overgeneralizing. I'm stupid, I'm lazy, it means somehow I'm a terrible failure. It's when you take a small thing and make it much bigger. That's also, by the way, maximizing negatives when it's negative. But I skipped minimizing positives. Minimizing positives is another cognitive distortion. And that means that when you understand that you've done something well, or somebody tells you you've done something well, minimizing positives is when you say, oh, it's nothing, or you're just saying that to me. So these distortions all contribute to people not feeling very happy, fulfilled, joyful. Shoulds and musts. It's real easy for us to internalize the rules that we're given as children, but even more so, depending on how we were parented, we're always at risk for being harsh self-critics. And shoulds and musts have a way of making us that way. When we think you should have done that, or he should have done that, or she should have done that. Labeling, I used the word stupid before when I talked about, if I didn't finish college, I'm stupid. That's labeling. Stupid, an idiot, lazy, that's labeling. Emotional reasoning is when you feel bad and somebody says, what's the matter? And you say, well, I'm miserable. And the person says, well, what'd you do wrong? And they say, well, I don't do anything right. And you say to them, well, what's your basis for saying that? Well, I feel bad, so I know I must have done something wrong. That's emotional reasoning. And fortune telling is when you anticipate in the future something terrible is going to happen. Finally, selective abstraction is when something happens in your world and you draw some conclusion that may be not only irrelevant, but also self-defeating. Like selective abstraction might be if you got a speeding ticket and you thought it was that everybody was after you. No matter what you did, somebody was going to screw you over, whether it was the police or the authorities in general or your neighbors. So an abstraction is when you draw some conclusion, but selectively means when you relate it to something specific that it might not be and might not relate to. So these cognitive distortions have the potential, as content to the way we think, the potential to make us miserable. System 1 and System 2 thinking. This is important, and I have built this into cognitive behavioral therapy because I think it's really valuable for us to know. Why would people have negative thoughts if they make them miserable? Why don't people just have constructive, objective, either positive or neutral thoughts? Well, early in life, we develop the way we view the world. We establish in our head how we think the world operates. And in order to make life doable, possible, in order to make it possible, we're able to function in what's known as System 1. System 1 thinking is very automatic, and it makes our days much simpler. If first thing in the morning what you do is, get out of bed, put on your slippers, as if people wear slippers anymore. I do. Go to the bathroom, do your business, brush your teeth. All of that is so automatic. And if it weren't, life would be very difficult. And that's all occurring because we possess System 1 thinking. We become intuitive about what we should do next. These thoughts become fast and automatic and effortless and implicit. And sometimes they're very emotional, but they certainly are efficient and they're appropriate for most decisions. And this System 1 and System 2 thinking was popularized by a guy named Daniel Kahneman, who actually won the Nobel Prize in economics for some of this work. So system one makes our life possible. The trouble is when we apply system one to, when we start thinking negative thoughts and they become fast and automatic and effortless and are related to emotional events, if they're negative, it's pretty hard to shake them. From an evolutionary standpoint, we had to have system one thinking, and it really needed to be quite sturdy or durable and not be easily knocked down, so that we didn't forget in the morning to wake up and brush our teeth. We just did it automatically. Or when we were actually in the presence of a person who was toxic or dangerous, system one enabled us to get away in a hurry before getting into trouble. So how do we change system one when it's so stubborn? We use system two, but system two is much slower and it requires more consciousness and effort, and it's much more explicit. It involves very careful analysis. It's logical and deliberate and intentional. Let me go back to that slide. So system one is what makes our worlds go around easily. You look outside, if it's raining, you don't try to figure out how to not get wet. You think, either I'm going to get wet or I'm going to put on a raincoat or bring an umbrella or at least a jacket with a hood. To change any habit like that, picture yourself trying to leave your cell phone at home for a day. You would automatically in system one be reaching for it. You'd want to check messages. You'd want to see if you got a call. You'd want to see if you thought you felt a vibration in your pocket. You'd reach for it. If you were trying to use your phone less, it would require a lot of slow, conscious, effortful, explicit hard work to logically make these changes. So to understand what makes people's lives hard or easy, it's important to conceptualize yourself, to actually think, what are my primary problems? What are my main problems? And in what social or environmental context do they occur? Distal antecedents, as in distant antecedents. An antecedent is something that precedes something. My primary problems that developed in a social or environmental context, long ago in the distance, what happened to me that made me that way? And proximal is current. And why do I stay this way presently? What reinforces that? So proximal and distal antecedents, if I am supposed to go for a job interview and I was always told that I'm stupid and I'll never amount to something, that's a distal antecedent that will make me pretty discouraged about going for the job interview. But if then I realize that I'm running late or I don't have the right attire, clothing that's proximal, that's present, and that can really unnerve me. And what more about the cognitive conceptualization, and conceptualization is just a fancy word for understanding how I think or how you think cognitively, how you feel emotionally, affectively, and how you act. Those are all part of the pattern. One other thing that's important to understanding yourself, again, if you want to really make sense of who you are or help somebody else make sense of who they are, very carefully laying out, what are my big problems? In what context are they occurring? What's reinforcing them? Who do I live with? Who do I talk to? Who do I hang around? How do I work? Who do I work with? How safe do I feel? How sheltered do I feel? How do I feel the people I care about? How do I believe they'll treat me? Going all the way into the past, distally, and going over the list again, and then proximally, what's happening today to me? And how do I think? Or what are my beliefs? How do I feel as a result? And then how do I act? And how ready am I to make changes if need be? And then putting that all together is called the integration of it all. That is what's important when you're trying to figure stuff out. So, let's continue. Things are more complex than they seem all the time. It's never just one trigger. Oops. it's never just one trigger that results in us having a strong response. You see on the left-hand side, to analyze any kind of problem that a person has in their lives, to analyze that, it's important to learn to look at these are on the left-hand side, trigger, cue, situation, context. Those are all what I called earlier. Let's go back to that slide. Those are all proximal antecedents, stuff going on in your world now. But it's not just one thing. It could be 3 triggers, it could be 4 triggers, it could be 10 triggers. It could be, not feeling well physically, which is a trigger. It could be having a family member that doesn't feel well. It could be having a family member that's been real critical. It could be it could be having a hangover. Those are all triggers or cues that are proximal. And these trigger what are called ATs, which are automatic thoughts. So if I, for example, had a hangover and I didn't like my job and I had to go to my job, and I had a disagreement with my partner, my first thought might be, oh, crap, what a day. Already, I can tell it's going to be lousy. Next automatic thought was, I don't really want to go to work. The next automatic thought could be, I wonder if I should just call in sick. The next automatic thought is, damn it, I don't have any sick days, sick time. Next automatic thought would think, my boss really sucks. He or she wouldn't cut me any slack. Next thought is, I give up. I have no answers. And the next thought is, just go back to bed. And behaviorally, I might go back to bed and lay in bed depressed. So that's emotions and behaviors. And they don't happen in a vacuum. Like this on the left is the proximal antecedent, the trigger, the cue, the situation, the context, triggering a bunch of automatic thoughts, which then lead to certain emotions and behaviors. But it's important to look at it in a developmental perspective. Now we look at distal antecedents. Some of it is just wiring or neurobiological. Some of it is psychosocial. Some of it's environmental. These early life experiences cause us to be more or less vulnerable. My deeply held beliefs or schemas, they're called sometimes, or thoughts, they develop early in life in our behavioral habits, how we compensate for like lack of certain skills, and our predominant emotions, those all develop early in life. And the more we experiment and engage in like addictive behaviors or problematic behaviors, the more they get reinforced. This is not just about addictions though. If a person is badly treated early in life and that would be psychosocial, and they live in an environment that doesn't nurture their growth, they never have adequate intellectual stimulation, there's a lot of crime in the area, and they have a family history of mental health problems neurobiologically, they may very well develop a vulnerability of negative thinking about themselves, about the world. But the experimentation and exposure, instead of addictive behaviors, it can be just going back to bed or deciding, I'm just not going to go to any social events. I don't need people in my life. But that vicious cycle on the bottom reinforces what was learned earlier in life. When you put that together with some of the vicious cycles, so you see what I just talked about at the top, and here at the bottom, you can see how the triggers, cues, and stimuli on the lower left side, internal and external, those learned thoughts and beliefs that follow those cues can really result in urges and cravings to go back to bed, to smoke a joint, to scream at somebody if that's a problematic behavior that a person has. So you see this is a vicious cycle on the lower left-hand side, but it was developed over time because of early life experiences that I just talked about. This was intended to show you how complex a person's identity is. People in the middle there, the identity involves how you view yourself and the world and other people and your future. Sometimes they're called schemas. Schemas and identity and self, they're all basic beliefs that when they get triggered, they're conditional beliefs. So if I believe, people aren't trustworthy. If I am meeting someone new and he says, hey, I have this really good blah, blah, blah. Your conditional belief is, if somebody promises me something that's too good to be true, in my world, I shouldn't trust them. My automatic thought might be to just blow them off. And, it could be that I'm telling you that I can find you, because of your circumstances, I can find you grants or some kind of subsidies to go to school because I'm trying to, I may represent a school that's trying to help people who are disadvantaged. But if you are a suspicious person whose basic beliefs are, I don't trust people and I don't trust myself, a conditional belief is if somebody offers you something, someone you don't know, don't take it. It's probably some kind of trick. That's the automatic thought. And the behavior might be avoidance and a negative emotion. But we have so many basic beliefs. We're not simple machines. We're very complex machines. This is just a close-up. So you may have real positive beliefs about yourself and your friendship network, but terrible beliefs about, your partner. Or you may have great beliefs about how well you function at work, but you may have terrible beliefs about, your ability to be a parent. And then again, the point here is just to show how complex humans are. So people with addictive behaviors get into vicious cycles. Once they have that exposure that I showed you earlier, their internal and external triggers get developed. And all they need to do is see somebody smoking a cigarette or drinking, or see a bar or see alcohol, and their automatic addiction-related thoughts might get activated, and they may get urges and cravings. But you can see how each thing that leads to the other can turn into one big vicious cycle. Just giving yourself permission on the lower left-hand oval, and then having a lapse can result in something that turns into a relapse, which can be the new trigger for more problems. For depression, so this is for addictive behaviors. For depression, internal triggers might be a conversation with somebody and during lunch, or a group of friends, and then while they're walking away saying, I had a wonderful lunch with friends, you might walk away, if you're a person that gets depressed, thinking they're more successful, they're smarter, they think I'm stupid, and you may even think I am stupid. Those will result in some pretty severe negative feelings, as you can see on the right-hand side. Envy, sadness, shame, anger, disgust. It's not the lunch itself that causes the problem. It's the thought, they're more successful, they're smarter, they think I'm stupid, and even I am stupid. So that's depression. And most people that have depression also have anxiety. Like if you're running 5 minutes late for a dental appointment, some people might think, wow, I'm only 5 minutes late. I'm sure they're not ready for me. But somebody with anxiety will think, I should never be late for anything. My dentist will fire me. The entire staff will be inconvenienced. I'm going to have those chest pains again. Those kinds of thoughts are what lead to these negative feelings you see here. So that's important to know. And anger. Anger is a big one. People who are angry generally have rules, and when people don't follow those rules, they allow themselves to get very upset by having very negative thoughts like, they shouldn't have done that. It's unacceptable. I can't stand it. I'll show them. And that can lead to feelings like irritation and anger and hostility and aggression. So the point here is that in cognitive behavioral therapy, there are some basic assumptions. And one of the most important basic assumption is that thoughts, sometimes absolutely invisible because they're automatic and instantaneous, and like I said earlier with System 1, they may be they show up with such ease that they're not even noticed. They take no effort. But if they become negative thoughts like people shouldn't do that, it's unacceptable, blah, 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 that can be problematic. Borderline personality, if you know anyone who has that, is when somebody has themes in their head like, I've been abandoned again, everyone leaves me, I can't stand it. Those will lead to a whole bunch of profoundly negative feelings like sadness and despair and loneliness and anxiety and hostility, all in one person, and all like a cascade of bad feelings. So when you go for therapy, what do they do to help you with this stuff? Well, hopefully it's a structured session where you both agree on what you're going to work on. Hopefully, a person learns to identify what mood or emotion is predominant in their current state. Hopefully, in good therapy, there's a bridge back to, what did we talk about in the past? So this enables the patient and the therapist to tie together all of the things that have been talked about in the past and emotion and all those diagrams I just showed you. And it's important for people in therapy to prioritize and discuss what's bothering them in some kind of a structured way. When therapy is just chatting superficially, like a couple of friends, it usually isn't any more effective than chatting with a friend. It feels more effective because it's a structured environment. And sometimes the honesty that people have when they talk to a therapist can be helpful. But adding to that, some aims and direction can really be helpful. That's done in guided discovery, where people learn skills and they give each other feedback. The helper or the clinician or the counselor or the therapist will say, tell me what you learned today. And the patient will say, well, what did you think about what I said today? And in good therapy, it goes back and forth. And in good therapy, there's homework. You don't just learn from the therapist, you go home and do something different. That makes a big difference. So here are some exercises that are really valuable that correspond with good cognitive behavioral therapy. Not all good cognitive behavioral therapies, but teaching people to identify situations that trigger emotions and then the automatic thoughts associated with them. And this is a daily thought record, and these should be done a couple of times a day initially so that people associate their emotions with situations or context, but also they associate them with certain thoughts that may be problematic, and they're able to generate new thoughts and new emotions. So it's good to do this formally for practice. It actually is very, very helpful because people, like I said, we operate in system one. Things go by automatically and instantaneously, and it's not ideal. And then looking at things intentionally, purposefully, looking at the advantages and disadvantages of any behavior is important. Being intentional is what's at stake here. And so actually saying, I'm going to stay in bed today and not get out of bed. What are the advantages? Well, I feel comfy. I don't have to take any risks. Nobody's going to yell at me. What are the disadvantages over in the lower right-hand corner, lower left-hand corner? Well, I miss another day's work and I lose a day of vacation or sick leave. What if I don't stay in bed as an advantage of not engaging in the behavior? Well, maybe I'll develop some resilience. Disadvantage of not engaging in it? Well, I won't be all comfy. So homework is essential for many people who get counseling, but if some people had homework, the word homework is ugly. Assignments need to be decided between the patient and the therapist. Like, what are you ready for? What do individuals, or if you're in a therapy group, if you are getting the help, it's up to you to decide, what are some good ideas for homework, and what relevant skills do I need to develop to become more healthy? So what are the barriers that might get in the way? By anticipating those barriers, it's much, much more likely that homework will be done successfully. And thinking about what the homework meant and how it worked out is essential. So this is an overview of cognitive behavioral therapy, not only how it's conceptualized or how it works, but also what a person might expect from being in therapy. And I sure hope it's helpful and appreciate the opportunity to share this with you. Thank you.